Hi guys, today I'm here with Lockie to do a little tutorial on cervical pain and headaches. So Lockie's been suffering from some cervical pain. I'm not going to go too much into the subjective, but we will talk a little bit about the things that you really want to know that are important. So let's just imagine that Lockie's already told me he's subjective, that he's had a 3 or 4 week history of right-sided upper neck pain and headaches. I guess the things we want to really be trying to find out is there any red flags or anything sinister going on? So we need to make sure we're asking questions around night pain. So have you had any night pain, Lockie? Any dizziness or fainting attacks, any of those sorts of things associated with your headaches? Yep. Can you show me where you get your headaches, where you actually feel them? In there? Yep. Do you get anything that is either behind or above the eye? No, it's more at the base of the skull. Yep. Different parts of the spine can refer to different parts of the head. So when we're looking at headaches, we really want to know about the location of them and the distribution of pain, if there's any referred pain. We also want to know about any significant weight loss. If you have any significant weight loss that's unexplained, Lockie? No. We've asked about night pain, so we're trying to rule out those more sinister causes. Have you had any loss of vision or any issues with your eyes? No? Okay. They're probably the main things. When you turn, I mean, you said you had no dizziness. If you turn your head a long way or quickly, do you ever get a bit fuzzy in the head or lightheaded? No. Okay, so that's good. So there we're looking for vertebro-basilar insufficiency or VBI issues. When we're doing manual therapy, it's important to be aware of the potential impact on the arteries going through the cervical spine, especially if you're doing high velocity thrusts of the neck. We're not going to teach that today. We're going to use more manual therapy skills that are the grades 2, 3, 4, not grade 5 thrusts. So we're going to go on to assessment now. So the first thing you want to do when you even have the person coming from the waiting room is to look at their posture and the way that they hold themselves and the way that they move. With Lockie sitting on the side of the bed here, he hasn't got any back support. He's probably a little bit forward with his scapula, a little bit protracted, and he's got that slightly forward head posture, but he's not as bad as me, the way that I'm sitting right here and right now, in that round-shouldered forward head posture. A lot of headache patients and a lot of neck pain patients do have postural changes or postural syndromes that are potentially putting increased load on their neck. When you're in that round-shouldered head forward posture, you tend to, if you're looking straight ahead, you end up tilting your upper cervical spine into extension and the lower cervical spine into flexion. So looking at biomechanics as part of your assessment and posture as part of your assessment. There's lots of things going around these days saying, does posture really matter? Look, I think anything that's put under load at end of range for a long period of time is going to be an issue. If we can take people more to mid-range sort of positions or be better at holding themselves or being able to change or adopt different postures, and developing awareness is important. So part of our treatment needs to be around what we do to try and relieve pain and to regain movement if it's lost, but also about changing what might be causing it. So looking at those things that are contributing. Do you mind popping your shirt off, Lockie, so we can have a bit of a look at you from range of movement? So we're going to look firstly at range of movement. So Lockie, if you can look straight ahead, you can tuck your chin down towards your chest for me, and any pain doing that. Okay, if you can tilt your head back up towards the roof now and show me how far you can go. Any pain doing that? A little bit. Yeah. Is that as far as you can go then? So it's got a little bit of pain. It's probably a lot more upper cervical there, and come back to the middle. Can you turn your head to look over your shoulder now? So we're looking at rotation. How does that feel? pain on that right side? Go to the other side. Any pain with that?
No.
If I come and just put a little bit of pressure there. So he's getting probably 80 to 90 degrees that way, just go that way again. And he's probably maybe 70 there. Okay, come back to the middle. Can you just tilt your head to the side for me, Lockie? Any pain doing that? And then go the other way. Okay, he's probably again got a little bit more range when he goes to the left than he does to the right. Okay, Lockie, can you just, like often for cervical, upper cervical issues or headaches, I also want to just have a look at whether we can reproduce any of their pain with a protraction or retraction movement. So Lockie, can you just poke your chin out going into that forward head posture? Any pain doing that? And bring your chin back and in as far as you can. Yep, any pain doing that? Okay, so sometimes you'll see a significant restriction with the retraction, particularly in someone who's got that really forward head posture. So they're the main things that we're looking for. Lockie, have you had any pain that's been radiating down your arm? So again, you're looking for referred pain. Is there any discogenic or any sort of somatic pain? So radicular pain, if there's a nerve being compressed, or somatic pain can come from any structure, whether it's muscular, joint, nerve. Quality and nature of the pain in those situations will be different. It will be vague, achy pain for the somatic pain and be sharp shooting pain for the radicular pain. Lockie hasn't got any arm pain, so we probably don't need to do a neurological assessment on Lockie because he hasn't got any specific nerve-related symptoms. Have you had any pins and needles or numbness would be another question that you're asking. Have you lost any power in your arm? So they're the sort of questions you'd be asking in your subjective, and that would lead you then to do a neurological examination. So we're not going to do that today. We're just going to focus on the neck because neck pain, headaches has been Lockie's presenting problem. We've noticed that Lockie's sitting up pretty straight now, going to a slouch slump sort of position. So if this is the way that Lockie presented, we'd be really sort of thinking, okay, automatically I'm thinking, what are the things that I need to address as part of the cause, as well as trying to help Lockie with his pain. The main thing he's come in for is that he's got pain. So when we're assessing someone, we also want to know what is it that you've come to see me for, what are your expectations of treatment today, and what is it stopping you from doing? What's their why? We want to find that out, and why is it a problem? So it might be that Lockie can't sleep, or it might, like he's having restless sleep, or it might be that he gets pain, he can't concentrate when he's doing his uni study, he can't sit at the computer for long enough because of it. It might be his ergonomics that are the issue if it's a computer thing. He might be working on a laptop, or he might be trying to read lecture notes on his iPhone. So questioning more deeply around those things in your subjective is really important, but we're going to go on now to the further parts of the objective assessment. So Lockie, I'm going to get you to lie on your tummy. Just going to get a bit right here. Just come on your stomach there. So I'm just going to do a palpation assessment now. I'm just going to bring the bed up so that it's at my height. Really important to make sure you look after yourself with your own ergonomics. So right-sided issue. Often when I start, I will just get a bit of a feel for muscle tension or tone. Is there overactivity, or is one side a lot bigger than the other? Just a surface sort of looking just generally through the lumbar spine, thoracic spine, cervical spine. Then coming back to palpating, generally I start centrally and I'll come up to the upper cervical spine, starting on about C2 there. And then often I come back up into C1. So to assess C1, you need to come in on that 30 to 45 degree angle. Any pain when I press up in there, Lockie?
A little bit.
A little bit there. And what about when I press there on C2?
No.
Yeah. I'm just going to work my way down and just get a general feel for the mobility in the cervical spine. So with Lockie, I'm feeling that generally he's a bit stiff in C1 and C2. He's actually quite mobile, and you could see with his range of movement he was actually pretty mobile. He didn't have and massive restriction in his range of motion. So just getting a general feel. Yeah, I'll often even come down and just, once I get to about T2, just get a bit of a feel for what their thoracic mobility is like. And look, again, in your assessment, you could go in and look at thoracic mobility, particularly the amount of mobility in the thoracic spine into extension. If you've got that round shouldered kyphotic posture, how stiff are they in the thoracic spine? Do we need to address that as part of our treatment? So right-sided problem, I'd probably come over here now, and again, coming right up into the base of the occiput, rolling off that and pressing on C1. How does that feel in there, Lockie?
Yeah, sore.
Yeah, so that's sore and tender in there. Like what I'm searching for and seeking is, does any of this actually reproduce your pain? So the pain that you've been experienced, does any of where I'm pressing here actually feel like it's in the region where you're getting your pain?
Yes, yeah.
Yeah.
Over there.
So is it worse when I'm there or there?
The first one.
The first one.
Yep.
Yeah. So now, is any of that causing pain to radiate into the head at all, or is it just where I'm pressing?
A little bit.
A little bit of radiation around. Okay. So I'm just going to come over to the other side. And how does it feel?
That's fine.
In there?
That's okay.
Yep. Okay. And again, I'm feeling that there's some relative stiffness in those upper cervical joints. When I get down to about C3, C4, it's really quite flexible and mobile in there and locking. I don't feel any significant restriction on that left side, and on the right side here, again, I actually feel a bit tight and stiff up in that upper cervical region, and then we're getting down into a region where it's actually moving a lot better. So our knowledge of headaches is that quite often it's from those upper cervical joints if there's going to be an articular reason for the pain, and if there's restriction there that reproduces their pain, you're highly likely to be on something that that you can alter. So in terms of treatment, yeah, I might also palpate the upper trapezius muscle. How does that feel when I do that, Lockie?
A little bit tender.
It's a little bit tender. Does any of that reproduce the pain that radiates into your head?
No.
No? Okay. And what about on that side?
That's fine.
Yep, so it's a little bit more tender on this side here. Yep. And if I come around and I squeeze on these muscles here, so I was on upper trapezius there before, it's notorious for trigger points for headaches. How does that feel when I squeeze on those muscles there? So now I'm on the sternocleidomastoid.
Yeah, that's okay.
Yep. And I can basically palpate and get a feel. You're feeling for a twitch response where there's sort of like a contraction within the muscle, or asking the patient, do they feel tenderness? Does it reproduce their headache? You can also do that in supine, but I find I can get a good feel of the sternocleidomastoid in this position here. Alright, so my findings on my assessment there that I think that I want to work with, some stiffness in the upper cervical facet joints on that right hand side, quite mobile through the middle. So now I'm going to move straight into a treatment technique where I'm mobilising that upper cervical spine. So I'm going to use, I'm around this way. Look, you can come from this way, but I find that I can access that upper cervical spine much better if I come from this area, and particularly the OC1, where you need to actually come in at that 45 degrees, getting under the base of the occiput, and yeah, basically both thumbs together, pushing and mobilising on that spot. How does that feel, Lockie?
Good.
So I'm going to do about 30 seconds on the OC1, and then I'm going to come down and do a similar amount of time on the C2 facet joint, C2-3. So basically I would do, yeah, after my assessment I might do 1 or 2 lots of 30 seconds there and then get Lockie to sit up again. So just come and sit up again, Lockie. And just be careful, the bed's not too high and he does a grind on the way down. So can you just have a go at turning your head to the side again for me? So our main areas that we asterisk signs were right rotation and cervical extension. How does that feel, Lockie?
Much better.
Much better. And then looking up towards the roof. How does that feel? Yeah. And Lockie's range was pretty good, but I reckon it does look a little bit better there. Again, if you come around this way again, if he was to say he had no pain there, I then might just add a bit of overpressure. How does that feel compared to before?
Yeah.
Alright, so my treatment's been effective. Come back on your tummy, Lockie. I'm just going to repeat what I did there. So I'm going to go back and do another set of mobs around that OC1 and C2-3 level. Essentially I'm using a grade 3. Because he had such a good response, I might even go a little bit more firmly with the next set. If he was irritable, then I might go a little bit less aggressively. Not aggressively, but less firmly. Alright, so doing those mobs again. Now, the other thing that, like that's using a purely joint mobilisation type approach. That might be enough to make a significant change for Lockie. Quite often when someone's been sore on one side, and Lockie's much more tender on this right side with his upper trapezius, I'll often add in doing some treatment with some massage. So just using some massage cream, just putting some through the top of the shoulder there. And look, when I do massage as part of my treatment, I'll tend to use both. I'll work the whole way through the neck rather than just being really focused on one point. Again, this is my approach and my technique. There's lots of different ways that you can approach manual therapy for the spine. I tend to find that if you use broad sort of strokes initially, like I think if you go straight in, you start digging and probing into a already sensitive muscle, that you can actually make it quite sensitive and tender. So just by working your way through that upper trapezius muscle with this sort of technique, you can also come from in above and work from the distal end of the muscle and work your way right up to the base of the skull. The suboccipital muscles are often also quite tender when someone's had an issue with upper cervical restriction or stiffness or tightness, and working your way through to treat by doing your massage through that area can be quite effective. So you might do 5 or 6 minutes of massage as part of your 30-minute consultation. Alright, so let's imagine I've done 5 or 6 minutes there. I'll just give that a bit of a wipe if I can find some tissues. Here we go. And then we're going to get Lockie up and we're going to prescribe some exercises for him. Okay, Lock, come and sit up for me again. Okay, so essentially with an upper cervical issue, Lockie's main areas where he was restricted on the objective assessment was right rotation and cervical extension. And look, a lot of people with cervical headaches will get some relief by doing retraction. Again, you want to look at what were the aggravating, what were the easing factors that the person found or you found in the subjective. So often with these sort of things, I'll do rotation, but often away from the side of the pain, stretching out the opposite side, opening up those joints and then also some upper cervical retraction. You've got to be careful not to give lots of exercise. Usually 1 or 2 is enough. So I'm going to give you 2 exercises, Lockie. The first one is I want you sitting up nice and tall to start, and then I want you to turn your head and look over your shoulder that way. Put your hand on your cheek and just push your cheekbone. So not your jawbone, your cheekbone, just to stretch, and then come back to the middle. And the other exercise is what we call a chin tuck. So if you put your fingers just in front of your chin like that, and then I want you to bring your chin in the way, but like, yeah, that's it. So you want to keep your vision horizontal, so pick a point on the wall and then come back again. So it doesn't have to be a strong, hard one, just gently retracting back. This stretches out the top part of your neck, but it also works these deep neck flexor muscles in the front of your neck, which help with stability and control and better posture. All right, so by being tall and then adding in that little bit of retraction, I'd like you to do about 10 of those, and then with the rotations, you do about 5 with a bit of a press where you hold for 5 seconds. It's a bit of a stretch. A little bit of discomfort's okay with it, but I don't want you forcing it into strong pain. And I'd like you to do that 3 or 4 times a day. Yep. All right, so a little bit often rather than a whole lot all at once. Pop your shirt back on, and have you got any questions about that, Lockie? Any comments just for the students or grads that are watching this video?
Not popped to mind at the moment.
No? Good. Okay, great.